First, regarding this case, actually, when she talked to us regarding there is a low TSH and a high T4, and patient has a hyperemesis gravidarum. So, basic physiology is very important. In the first trimester, there will be increased level of this T3 and T4, and TSH may be normal, TSH may be high, TSH may be low in case of hyperthyroidism. The simple reason is because there is increased level of the HCG, and this HCG by this test it will mimic just like TSH. So there may be increased level or normal level of TSH. So that is one important point. So basic thing is we should do the free T4 level. If the free T4 level is high, definitely we will go for this thing. It is a case of hyperthyroidism along with the basic the symptoms. Symptoms is also very important. And if we do the plain T4 without any free T4, then the guideline, approximate guideline is it should be more than 20 nanogram per dl. That is important. If we cannot do the FT4, and absolutely correct what she has told, there are lots of indications for screening test of thyroid in case of pregnancy, particularly if the patient is suffering from first is the important is the clinical manifestations. If there is because in hypo and hyperthyroidism in pregnancy, the symptoms will not differ. It will be just like non-pregnant type. But important is if there is a family history of any autoimmune disease, if the patient is suffering from diabetes mellitus type 1. So in these particular cases, we should ask for this thyroid profile. Another important thing, hypo and hyper, which one is more common? Hypo is more common than hyper. The reason, simple reason is the Graves' disease is the commonest cause of this hyperthyroidism in pregnancy. But one important thing is Graves' disease is there will be anovulatory cycle. So naturally, chances of pregnancy is very less in case of Graves' disease, number one. And number two, any autoimmune disease will be reduced in case of pregnancy. So the hypothyroidism is much more common than the hyperthyroidism. Regarding the treatment part, you may give the propylthyrosol or you may give the methimazole, carbimazole. But most important is propylthyrosol. I think it is not available in our country, so we have to give this methimazole. Better to give within 20 milligram per day, not the fullest dose. The reason, simple reason, it will pass through the placenta and it will produce the hypothyroidism of the baby. So, as per recommendation of CMDT latest guideline, maximum you can give up to 20 milligram per day. Regarding neonatal screening, it has already come. At least I think 3 to 4 years back, everybody is telling the IAP guideline is also the thyroid. Dr. Shetty, thyroid guideline is we should do the neonatal screening. There is no inch of doubt.
Actually, the incidence of hyperthyroidism in newborn is 1:4,000.
Yes.
So that's why the screening procedure.
Universal screening should be there if it is possible.
So they are taking cord blood just after the birth in a blotting paper. Probably that is a chromatography paper, and that is being sent to ICMR. So with the phone number, if it is detected, then immediately the child is being treated. And in during pregnancy condition, if mother is hypothyroid, usually the dose is double the normal. If mother is getting 100 microgram, during pregnancy you will require at least 200 microgram.
It should be at least 20 to 30% of the normal what we give in case of hypothyroidism. Dose is definitely has to be increased because the requirement is much more.
During pregnancy, if a patient is getting methimazole, how do you follow the patient fetus for the side effect of methimazole? That is fetal.
Fetal methimazole, it is very difficult because
Fetal aplasia can happen.
Aplasia cutis, aplasia may be there, or guanal atresia or esophageal atresia. It is very difficult. But the common side effect of this methimazole or carmimazole is this agranulocytosis. So that is very important. First 7 to 10 days we will do it. After that 15 days interval, after that 1 month interval. And particularly if there will be any sore or fever, we will ask the patient to stop it, then come to the doctor. First stop the drug, then come to the doctor. We have to check it at a regular interval. And it is without this regular interval checkup, it is very difficult to control it because patient may land up into this agranulocytosis with severe infection. So that is important. Okay, thank you.
I just want to cite one case recently I saw.